Good evening, everybody. Thank you so much for joining me tonight on YouTube Live. I'm Dr. Howard Elkin, the medical advocate, and this is Heart Month. February is Heart Month, and it's a red letter day. I'm actually wearing red, as you can see. Actually, yesterday was special. Besides being Valentine's Day, was my youngest daughter gave birth to my youngest grandchild, Sky Lily. She was born yesterday at 11:45, right at the end of Valentine's Day. So it's a very special occasion for us. But it's a special occasion for all of us, and this is a time that we really commemorate or celebrate Heart Month, and for good reason. It's still the number one killer of both men and women. It's an equal opportunity killer. And so I always like to start off with the grim statistics because it kind of puts things in perspective. And that's really why we celebrate this month, because it is so important. So 697,000 people, which is almost 700,000 people, die of heart disease every single year in this country. That's really 1 out of 4. And if you look at of all the heart diseases out there, the most common, of course, is coronary artery disease. And that kills about close to 400,000 individuals a year. So almost half of the individuals that die of heart disease die of coronary artery disease. About over 800,000 individuals have a heart attack every year. 800,000 heart attacks in this country a year. And of that 800,000, about 605,000 is their first event. It's a lot. And the scary part to me is that 45% of heart attacks are silent, which means people really don't have any symptoms. So they really don't know. And that's why it's so important to be aware of this. And always end with someone dies of heart disease in this country every 33 seconds. So the prevalence is enormous. And putting it in perspective, when you compare this to COVID, because I know we've heard COVID over the last 4 years, it's driven us all crazy. But even at the height of the pandemic in 2020, twice as many people were dying of heart disease than COVID. So it still has surpassed everything that you can imagine. So I always like to start off with assessing your risk. What is your risk? Because if you're low risk, what do you need to treat? If you're high risk, you need to be very aggressive with treatment. So it makes a big difference. I'm all about knowing your risk. And I tell people when they come to my office, my patients, I don't really care about your numbers. I mean, I do care about your numbers, but I'm more concerned with your individual risk. So that's going to help what recommendations I give you with regard to therapy. Now, there's 5 major risk factors, which we're not going to really talk about tonight unless you ask me in the Q&As. Actually, 6, okay? 1, hypertension. Number 2, smoking. Number 3, cholesterol. I know this cholesterol issue is very confusing these days, but cholesterol was still a major risk factor. 4, diabetes. 5, obesity. And 6, physical inactivity or lack of exercise. Now, the interesting thing about it, the first 5 all have to do with excess blood pressure, excess smoking, excess cholesterol, excess fat, excess blood sugar, excess pounds. But number 6 is lack of one thing, and that's physical exercise. It's so important. But I really want to focus on some of the secondary risk factors, and they're the ones that you probably don't know as much about. Such as LDL particle number, LDL particle size, APOE, homocysteine, C-reactive protein, fibrinogen, oxidized LDL. These are terms that you probably won't hear from your average cardiologist or average practitioner. They don't really go into that type of detail. But personally, as an integrative cardiologist, I feel that it is essential. So we're not going to focus on the big 6 because you all know about that. We're going to focus on the other ones. So LDL, now, when you go to get your regular lipid panel, your doctor's going to order what's called a standard lipid panel or coronary risk panel. So what you're going to get is total cholesterol, HDL cholesterol. HDL ought to be healthy, but it's not quite that simple. LDL, lousy, cholesterol, and triglycerides at a ratio. That's really it. They don't really order anything else, but there are better tests, and we're going to talk about those right now. One is LDL particle number. Now, so the LDL, this measures the actual number of LDL particles in your blood, not just the concentration, but the actual number of LDL particles in your blood. And it's thought in the cardiology circle that actually the actual numbers, the number of LDL particles, is more prognostically important than just knowing the LDL in itself. So, because LDL just doesn't, doesn't exist by itself. It's all attached to a protein moiety. So LDL particle is important, but what I care about more than LDL particle number is the LDL particle size. What is the size of the LDL particle? And if anyone follow up with me, they know one thing: big is better. Okay, the larger the particle size, the LDL particle size, which includes things like we call it the large buoyant size. That's the most healthy one to have versus small dense. Why? Because small dense is more likely to get oxidized, which is actually a chemical change. So once it becomes oxidized, that's the LDL that we worry about. That's the one that can go into the walls of the artery and form plaque. So again, small dense is less favorable than large fluffy or large buoyant. And there are tests that you can easily tell that. Then there's ApoB, which is probably the most specific test. So LDL is commonly used by all of us, but ApoB and LDL particle number are a little more specific because ApoB measures all the atherogenic particles, not just the LDL. But LDL is still commonly used, and I use it myself because about 90% of your atherogenic particles are involved with LDL. So you might miss 10%, but if you want the most accurate number, you want to look at your ApoB level, which is easily done. Most doctors don't order it, but it's not an expensive test. It's like $50 or less. So ApoB is important to order. Other things is other tests that I like is oxidized LDL. So again, we can actually measure that. Cleveland Heart Lab does it, and also Boston Heart Lab or Boston Diagnostics. So again, once LDL is oxidized, it's changed. It's a different moiety. It becomes dangerous. It can enter the walls of the artery and cause plaque. So it's nice to know, the size of the LDL particle and whether or not there's oxidation of that particle. There's another one you probably heard of. It's called LP little a. So it's LP little a in parentheses. That's a fragment of LDL. And it's not uncommon. Probably about 20 to 25% of the population has LP little a. It's genetic. It's not easily treated with drugs or diet or exercise. There's something that we could use to treat it called niacin, which actually is a vitamin. But it's nice to know if you have it because it is genetic and it does carry a worse prognosis because it's so atherogenic. It's a sticky, inflammatory fragment of LDL that loves to get into those arteries and cause plaque. So again, LP little a, you don't know if you have it if you don't check for it. Yep. Also, triglycerides. Now, triglycerides is part of your standard panel, but it's never been really elevated to the level of like cholesterol and HDL and LDL. But I think it's very important because it tells me about you, and you also about your cardiometabolic health, your metabolic health. People with high triglycerides tend to not be healthy. Why is it a big deal? Because about only 5% of the American population is really metabolically healthy. So when I see high triglycerides and a low HDL, I'm thinking, okay, this is a dangerous situation. We often see it in diabetics, but so triglycerides may not be a major risk factor for heart disease at this standpoint, but it does tell me about your metabolic health, the state of your metabolic health, which is very, very important. Homocysteine is one that I always check. So homocysteine, excuse me, is a breakdown product of protein. So you can't avoid it unless you don't eat protein, which I certainly would never advise. And but some of us have difficulty in breaking it down. And there's actually a genetic test, which I'll talk about in a minute, that actually can detect this. If we are poor methylators, that means we don't break it down, and we need B vitamins to help us along the way. Why is homocysteine important? Because it is definitely another risk factor for heart disease, and it can also accentuate the whole plaque process. Most important, it can interfere with nitric oxide production. So nitric oxide is actually a gas, but it's like a signaling molecule. So within a millisecond, it's changed to a different entity. But with nitric oxide levels that are high, the arteries can stay open and supple. And once you have a lack of nitric oxide, which comes along with a lot of different things called aging. But anyway, and homocysteine that elevated can also interfere with nitric oxide production. So I always check it, and it's easy to treat. Inflammatory markers. Okay, anybody that comes to me knows how I'm so big on inflammation. Why? Because inflammation is the bane of our existence as it comes to aging. So I don't care. The big four that I always talk about is heart disease, cancer, autoimmune disorders, Alzheimer's. What do they have in common besides you're more likely to get afflicted as you get older? The fact that they all have inflammation as at its core. So how do you know if you have inflammation? We look at things like C-reactive protein, which is a very sensitive test. I mean, if you have a cold, if you have COVID, if you have a tooth infection, if you have an ear infection, it'll register as being elevated. And that's actually a good thing because it's your body's way of taking care of you, by warding off disease, warding off pathogens. So that's when you want to see an elevated level of C-reactive protein or fibrinogen, which is another inflammatory marker. But I have patients that are walking around 24/7, 365 days of the year, and with really elevated C-reactive proteins. And we really have to, I think it's important to work that up. Again, if you don't know your levels, how do you know if you have it? And I don't think, like I said, most doctors are not ordering these tests. So C-reactive proteins, these are both made in the liver. The other one's called fibrinogen, which is an active phase reactant, which usually if one is elevated, the other one is elevated. So it's just kind of two of the same. Then I look at metabolic markers, very important. I already alluded to the fact that we are not a healthy country. Okay. Now there was an NHANES study, funded by the government, and it was put out by University of North Carolina, Chapel Hill, before COVID. I think it was 2020, or maybe to the end of 2020. And they found that only 12% of the adult American population is metabolically healthy. Fortunately, I was in that class, but I do take very good care of myself. But it's something that we have to know because it got worse with COVID, as you can imagine. So now the numbers are much worse. Like only 5% of the adult American population is metabolically healthy. So this is a big deal. And if your doctors aren't ordering it, you're at a loss. So what are the most important ones? Hemoglobin A1C, which is actually a marker in your blood cell. That tells me how well your blood sugar has been controlled for the previous 3 months. Now, red blood cells last 3 months, 90 days. So what you see now won't be, if you start testing now, in 3 months, you'll get an idea of where you are with your diet and with your program. But that tells us really where you're doing, where your sugar is. So the levels are, if it's less than 5.7, you're normal. If you're 5.7 to 6.4, you're pre-diabetic. If you're over 6.4, you're a diabetic. And you can go from one class to another, but it's really important to keep this in mind. So yes, checking your blood sugar is fine. I actually prefer these what do you call it? These continuous glucose monitors. You can get them. I think Medicare does cover it. I don't think most PPOs do. You put it right here, like where your tricep muscle is there, and you actually, it works fantastic. So if you wanted to see how you're doing, you eat a bagel, or you eat an apple, or you eat whatever, you put your phone as an app. You put your phone right next to this marker. The little needle here that stays in your arm for 2 weeks, 14 days. It'll tell you instantly what your blood sugar is. Because if I eat a bagel, my blood sugar may go up 30 points. Yours may go up 80 points. How do we know? We don't know because everybody's different. But the continuous glucose monitor is a really cool tool to monitor, where you're going with that. But the A1C is important for me to see as a physician, to see where you are doing, how you've done over the previous 3 months. I also look at your fasting insulin level. I never see this done by regular physicians, your standard physician. But it's very important because type 2 diabetes and metabolic syndrome and prediabetes, the common denominator is that these are all hyperinsulinemias, which means the insulin levels are way too high. How do you know? If you don't check the insulin level, and it has to be done fasting. So I like to have a level less than 7. Okay. Most of my patients, before I get my hands on them, have levels of like 20 and 30. It's really high. It's really not good. So that means your pancreas is pumping out insulin to help get the insulin into the muscles and the liver for storage. But because the cells don't recognize it, they don't open the gate to allow it in. So what's the pancreas do? Puts out more insulin, which is the last thing you want because insulin is a fat storage hormone. So it makes it very difficult to lose weight. And it's also deleterious to the heart. So we don't like elevated insulin levels at all. Again, how do you know it if you don't test for it? Another one I look at is called C-peptide, C-peptide, P-E-P-T-I-D-E. That tells me how hard your pancreas is working. If I see your level is really high, that means your pancreas is working. It's working its tail off to not make you diabetic. So you can have an elevated insulin, you could have an elevated C-peptide, and have a normal hemoglobin A1C because your body's trying to not make you diabetic. Eventually, it fails. But again, these are tests for metabolic health. Then I also look at some genetic markers. You probably heard the one, the MTHFR. We commonly call that the gene because it looks like that. But it's methyl tetrahydrofolate reductase, big term. And that really tells us, that's the genetic test that tells us whether or not we have a genetic variant. I don't call it a mutation. It's because it's so common, but I call it a variant. And 60% of us have one or two copies. There's two different things that we look at, C77 and 1298 on different chromosomes, and it tells us if we're positive for this, and like I said, it's in more than 50% of the population, that means we tend to be poor methylators. Now, let me give you a funny example of this, because genetics doesn't tell the whole story. So I have one copy of each of those two variants. So I should have a really high homocysteine level, but knock on wood, whenever I check it, which is at least twice a year, my levels are always normal, which means even though I have the gene, it's not being expressed. And that's what you want. You want the good genes to be expressed and bad genes to not be expressed. You want them to be suppressed. And I would like to think it's maybe all that I'm doing with my my lifestyle management to help disallow that gene from being, to be expressed. It's very interesting. So these are new tests and I'm going to tell you right off the bat, most doctors do not order these tests for a lot of reasons. First of all, they don't even know these tests themselves. To sit down with the patient and to really go over these tests in detail, it's a lengthy process. Now, I've got it down because my patients get it done repeatedly. So the first time we do it, may take a longer time than other times, but this is what I do. This is what I want to do. I want to teach and empower my patients to take good care of themselves. But how can we do that if we don't know your risk? And we're not doing the studies to assess that risk. So this is really what I want to get across. And it's so important because I just see this not happening. It is happening maybe in the functional medicine world, but most cardiologists are not functional medicine practitioners. I am a rare bird. I am definitely out of the box, but I don't know so much about how great it is to be outside the box. My idea is to make the box bigger. And that way, I do both. I'm traditionally trained, but I have taught, through lots of training and so forth, I've gone outside that box or enlarging my box so that I know what to test and how to help my patients the most. So it's a shame that most doctors aren't doing it. A lot of chiropractors are doing this testing, and a lot of other allied health professionals, but it'd be really nice if more cardiologists were involved. I shouldn't be the only guy in town because this is the crux of the matter. Because again, I don't care about your numbers as much as I care about your actual risk. Now, what about this thing with genetics? Now, I was thought that up to maybe a year or so ago that genetics, maybe your clinical outcome is genetically determined in 20-30% of cases. Okay, but now it's been really downgraded, and it's thought that your genetics probably only dictate 5%, 10% at the most of your clinical outcome. So when people start saying, well, it's in my genes, I'm going to die of a heart attack. If you want it to happen that way, it will. Okay. But you don't have to be your genetics. So I always tell people, okay, you have this genome, which is the gun. Okay. And then you have the trigger. And once you pull that trigger, things happen. You can have a genome. And then once you pull the trigger, then we get to see what's being expressed. That whole science is called epigenetics. It's a very exciting part. So I'm really more interested in epigenetics and genetics. And there are tests that you can do to look at your epigenetic profile. Because again, we want In lifestyle management, we'll talk more about in 2 weeks. We want to we want the good genes to be expressed and the bad genes to be suppressed. So again, it's knowing your risk. Now, who is high risk and who's low risk? Because I've talked about this repeatedly. So who's high risk? I am. Okay. I've had previous stent before. Okay. If you have known heart attack or a stroke, or if you had a stent, or you've had bypass graft surgery, or you have a high calcium count, which we'll talk about in a few minutes, you're automatically high risk. If you're a diabetic, you're high risk because 70% of diabetics will have a heart attack in their or a stroke in their lifetime. So diabetics are high risk. Those with previous history of heart disease are high risk. People with peripheral artery disease are high risk. People with carotid disease are high risk because it's really the same process. It's plaque deposition within the arteries, just in a different location. So again, I treat my high risk patients much more aggressively than I would treat my low risk patients. I've seen patients come to me from other doctors on statins, high dose statins. And I'm not a statin basher, but I don't believe in overstatinization, term that I kind of made up. Because why treat someone aggressively who's not high risk? It's ridiculous, right? But the ones that, and this is what we have found in clinical practice, the patients that really need the most aggressive treatment, that's people with coronary disease, aren't being aggressively treated. Their blood pressures aren't that well controlled. Their cholesterol is not really up to the new standards. We have new standards now. So it's really important for you guys to know your risk because your doctor may or may not make a big deal about it. See, a lot of people in traditional medicine are just one size fits all. You've seen it. You know it. Okay. I think to me is not the way I practice medicine. I believe in precision medicine based on your profile. And again, so we're talking about heart disease, we're talking low risk versus high risk. So that's basically how we break that down. Now, what tests do we order besides the laboratory test that I just mentioned? Well, if you have symptoms, we're going to do a type of a stress test. That's kind of a no-brainer, right? If you have chest pain, shortness of breath, or something that I don't think sounds good or you don't think sounds good, we'll order a stress test. And it's really interesting. I always do a stress test with imaging, meaning either an echo, an ultrasound, or a nuclear stress test. There's both imaging techniques that we use with stress testing. Your insurance, if they want to just do a standard stress test, that there's no reason to do a standard stress test in this day and age. It is so last century. It's ridiculous. But again, if you expect insurance to care about you and your health, you're wrong. You are wrong. It's you have to be your own medical advocate, which is what I've talked about forever and focus in my book. So being your own medical advocate means you take the bull by the horn and you demand that certain tests get done. But I have seen a lot of the insurances don't want to pay for a stress echo. They'll just do a regular treadmill. In women alone, a regular treadmill is ridiculous because there's so many false positives. So I have to work very hard to get these tests actually to be said your insurance will cover them, reimburse. It's crazy. Okay. We talked about all these lab tests, but I want you to know about these tests is that they're not what the average doctor recommends or what they test for, but it's very important. So how do you get these done? There's two labs that I gravitate toward. One is Boston Heart Diagnostics and one is Cleveland Heart Lab. I probably use Cleveland more, not because it's better. I think they're both very equal. But the thing about Cleveland was bought up by Quest Diagnostics about maybe 7 years ago. So all you got to do is go to Quest with a Cleveland form. And so and then the blood is actually shipped to Cleveland and they're brought back. The results are brought back. So, so it's very accessible to have the specialized lipid testing and metabolic profile and the genetic profile and all the stuff if you go through Cleveland and Quest. But Boston is good as well. You have to go to a phlebotomist that knows how to draw it. Now, I want to talk briefly about the CAC scan, coronary artery calcium scan. That's a great test for screening. I don't like to do that screening because what happens, insurance doesn't want to pay for it. For some reason, Medicare will pay for it, but not PPO insurance. It's $190. It's really well spent money. So it's a 5-minute test. I only bring patients to one place, Harbor UCLA, because they have the most updated equipment. Dr. Mark Budoff does a wonderful job, and this is the most efficient. And so you get a score, of the amount of calcium in your three major coronary arteries. And the ideal score is 0. You don't want any calcium in your arteries, but as we get older, that seems less likely. So 0 is perfect score. A 1 to 99 is mild disease. So we go up to maybe 300 or so, it's moderate. Then over to 400 is considered severe. So you have mild, moderate, and severe. But that's only looking at hard tissue plaque, calcified plaque. Keep in mind that most plaque is not hard cap plaque, it's soft plaque, which we'll talk about in a minute. So, but it is a good screening method because I'll find out, well, you've got coronary disease. If you've got a positive scan, no matter how high it is or low it is, you do have coronary disease. And also the beauty of Harbor UCLA, they have a database of about 30,000 patients. So I can tell you, how do you fit in with the profile of a 40-year-old male or a 60-year-old female, because we're comparing you to your age and gender. So the number may be like 40 or 50, which seems pretty low, right? I said less than 99 is low risk. But if you're a female and you're, let's say, not that old, then all of a sudden you're going to be in the high percentile. So you want to know the amount of calcium, and you want to be tested against your peers, meaning age and gender. And Harbor usually does a terrific job of that. So that's the coronary scan. Now, there's a new kit on the block that I am becoming pretty adept at ordering. It's called the Clearly Scan, Cleerly. I touched upon this about 4 or 5 months ago when I was discussing new cutting-edge stuff in cardiology. So this is a combination of CT angiography with artificial intelligence, and it's a game changer. So what happens, I bring these patients to Harbor UCLA. They do a peripheral IV, in your veins. I can tell you these veins here, and with contrast, and we get to see are there any blockages. It's not as quite as specific as a standard angiogram, which is under the groin or the artery here, but it's pretty darn good. So it'll let us know at least whether or not you have any major blockages within the 3 major arteries. But then we go over to the Clearly, we add that to it, and for the first time in history, we now can look at plaque composition and plaque volume, which is very, very important. So let's say with the standard coronary calcium scan, all you could tell was calcium, hard plaque. Now we can tell whether or not you have soft plaque. Okay, and there's something else that's even more significant called low density soft plaque or low density plaque. This is a plaque that's worrisome. This is a soft plaque that can break off and rupture and cause a heart attack. Calcified plaque is actually somewhat protective. You actually want to have more calcified plaque than non-calcified plaque. But once soft plaque becomes low density, then it becomes very soft. And I'm hoping that we can spare some of those horrible figures I told you at the beginning about the grim statistics. If we can find people earlier and test them for this with a Clearly scan, the soft tissue plaque, specifically the low density, because these people have a definite high chance of having a heart attack. So why is it important? Even an angiogram cannot detect plaque composition. It'll tell you how blocked something is. 60%, it's 80%, it's 100% blocked. It's good for that, but it won't tell you the composition of the plaque because you can't tell. This Clearly scan will tell you. So let's say I've seen this number of times, and I had a plaque rupture with a 50% blockage. So most blockages that actually lead to heart attacks are not 90%ers, usually 40, 50%er, and they become unstable and they rupture. But now we'll be able to figure this out if we can do a Clearly scan. Now, I can't think we can do a Clearly scan on every individual out there, but we haven't quite figured out where this fits in. But I just want you to know about it, because if you come to me, this is a test we can do that will really differentiate hard plaque from soft plaque. Soft plaque is more vulnerable, especially low density, and that's the kind that could break off and cause a heart attack. So it's a game changer. You'll be hearing more about it. I don't know how it got the name Clearly, Cleerly, but anyway, it's a great test. It's a short test, and hopefully insurance will be more forthcoming in reimbursing with this as we keep going. One more test I want to talk about, then I'll take your questions. It was called the Pulse test, PULS. Now it's called Smart Vascular DX. This is a different type of test. It's a blood test. Only requires 2 vials of blood. And it's looking at the health of your endothelium. Now, if you look at your blood vessels, We all have 60,000 miles of blood vessels within our body, 60,000 miles. And they all are lined with one cell called the endothelium. Endo means inside in Greek. That's a semi-permeable cell, and its job is to keep out LDL, oxidized LDL, and other pollutants and stuff from going into the wall of the artery, causing damage and causing plaque. So now, why do we even care? Because if your endothelium is healthy, I don't care if your cholesterol is 300. Ain't nothing going to happen. But most people do not have a healthy endothelium. So this is where standard cardiology goes wrong, and also standard medicine. They're looking at your numbers. Well, what's your LDL? Or they may look at your coronary calcium scan. But if you know that the endothelium is unhealthy, that's inviting. That takes place way before you have LDL cholesterol oxidized going into the walls of the artery. So it's to me, it's like almost an oxymoron to not test for this, but very few people were testing for it. So again, it's a test. It's based on 7 biomarkers. It's really fascinating how this test was started. So they was testing initially after when it was being developed a few years ago. They started off testing 250 different proteins seen in vulnerable plaque in both humans and mice. And then over a period of a few years, they narrowed down to 45. And then recently, and then 9, and now actually 7. And they've used 3 different statistical systems to actually confirm it, the validity of the test. And it's the National Heart and Blood Lung Institute. The National Heart and Blood Lung Institute, which is the government, of course, has approved this. So it's FDA approved. It's a good test. Why is there no interest in it? There's no money in it. There's no drugs that will treat your endothelium. There are supplements, and I sell them here. And I've seen the pulse score improve with the use of supplements. So we want to protect the endothelium. We want to protect the inner lining of all of our blood vessels, and we can do it with supplements. And of course, lifestyle, but drugs won't do it. Before we finish, I want to talk about gender differences because, I want you to know that men and women, men are from Mars, women from Venus. So there's no question about it, especially as it relates to the heart. Now, in lots of different ways. First of all, the biology is different. Women tend to have smaller hearts, and they tend to have smaller blood vessels in the heart itself. And they tend to have built up in different areas. Men have it in the larger arteries, and women tend to have built up in the small arteries that you can't even see. And it's called microcirculation or microangina. Now, it can present the same way with chest pain. You can conceivably have a heart attack. That's less likely because it's small vessel, but the treatment is oftentimes the same. But you have to remember, women tend to have microvascular angina, and men don't. So and that's because this plaque is building up in different areas in the small vessels. The symptoms are very different too. You rarely have a woman with crushing chest pain with pain down the left arm. That's not very infrequent. With women, it can be nausea, vomiting, it can be dizziness, it can be extreme fatigue, shortness of breath. It doesn't have to be any of it. Doesn't have to be painful at all. But the thing to look out for women, if there's pain in the jaw or the teeth, that's a red flag for women. So we always look out for that. And there's also other entities that women get. They can get spasm of the artery. They can get something called spontaneous coronary SCD, spontaneous coronary dissection, usually seen in middle-aged women. I've had about 3 or 4 of them, in which it's usually a small artery involved that dissects, which is it's torn. We don't know really what leads to it. These women are not unhealthy, but they can have a heart attack. But usually you can't really stent it or do anything about it because they're very small vessels. But again, we want to just keep that in mind. And there's one other thing I want to end with, and this is something that since my daughter works in labor and delivery, just had a baby yesterday, but I'm interested. I do treat some women that have gone through pregnancies, but it used to be if you had eclampsia or one of these GYN disorders, there's no big deal. If you outgrow it once you have the baby, you're okay. But now, as cardiologists, we're taught to it still is a red flag. So if you have gestational diabetes, you have diabetes while you're pregnant and it goes away, or hypertension, or a preeclampsia, okay, these are powerful predictors of cardiac risk later in life. So these women are not scot-free, even though those those entities may go away. They may come back, and they may have coronary disease. They're definitely at high risk for coronary disease as they get older. So preeclampsia, gestational diabetes, gestational hypertension, and also women age 40 or younger with endometriosis. Endometriosis is, and you're 3 times more likely to have a heart attack with a history of endometriosis if you're under the age of 40. And that was a study done at Brigham Hospital. So, besides that, women, it's a whole different ballpark. That what we look for when someone has a heart attack is an enzyme called troponin, but women don't secrete as much troponin as men. So now we're coming out with different levels of your troponin level. If it's here for women, it's positive, but for men, it would have to be here. So we have to again know the difference and interpreting these enzymes that predict cardiac damage in men versus women. But, it doesn't matter. The bottom line, it doesn't matter where your pain is, what your pain is. If you, as your own medical advocate, wake up with I woke up several months ago. I've disclosed this before. I had a very stressful the end of 2022 and all of 2023. And, I lost my partner and other things took place. But I woke up at 3:15 in the morning on a Saturday night, and this arm, my right arm, sorry, not my left, my right, I felt like it was on fire. I mean, like someone had lit a match and poured gasoline fluid all over me. It was really crazy. Anyway, but I knew what to do this time. It was the first time around. And I was alone, so I dialed 911, went away. I was brought to the hospital within minutes. And although my EKG was totally normal, I had elevated troponin, and I had a significant blockage in my main left coronary artery. So my ending thing to you is that if you feel something that's different, that doesn't feel normal, dial 911, get yourself to the hospital. Don't second guess yourself. Because the first time around, I did. And, and it's all in my book on both sides of the table. When doctor becomes patient. So I've been a patient twice, actually 3 times now, but I'm doing very well, thanks. So that's how we end it. And I got all these great questions. So let me, oh boy. Okay. I'm going to start at the, I guess, top and go down. Okay. Does niacin have any proven outcomes? Absolutely. Now, niacin is not used by a lot of doctors because it got a bad rap with some VA study a few years ago. It is not nearly as potent as a statin. Okay, I want to make that quite clear. Statins are the best when it comes to if you just want to decrease LDL cholesterol. But if you're interested in decreasing Lp(a) or making a small particle into a large particle, because bigger is better, then niacin can be useful. It can be useful, but you generally need large doses. So I usually start people with 500 milligrams twice a day and move up to 2 grams. So I have found it to be useful. It's been around forever, longer than statins. So I do have, it's like I said, it does definitely have utility. Okay, Bronco, thank you. What is the minimum dosage of homocysteine that you recommend? Well, homocysteine, okay, so I have my own formula. Okay, my formula has 2 milligrams of methylated folate. It's got 50 milligrams of vitamin B6, and it's got 1,000 micrograms of methylated B12, and it has something called TMG, trimethylglycine. They work together to bring down your homocysteine level. So it's called homocysteine X because we want to X out the homocysteine. You need all 3 of those vitamins, but here's what you got to know: B12 and B12 and B9. B9 is folate. Have to be methylated. Okay, that's why you don't want to go to regular B complex, because most B complex medications and multivitamins are not methylated B vitamins. Okay, so you have to make sure that the B12 is methylated and the folate is methylated. Otherwise, you won't see a reduction. So, but it usually goes away. It comes down pretty well. Is there anything that can replace niacin for those who can't tell? No, there's no real. There's unfortunately there's not, and here's why. The non-flush niacin, which they sell it at Rite Aid and Target and so forth. It doesn't work. It's been chemically changed. It's been chemically altered. So it's not going to work the way regular flush niacin would. Now, I know Bracco pretty well here. He was one of the few people that actually had, I don't want to talk about you, some abnormal liver function. It's common to see that with statins. It's very uncommon to see it with niacin, but I have seen it in 3 or 4 patients. So, so obviously that's a contraindication. So unfortunately, there's nothing at this time that can replace niacin for those that have an allergy to it, or that or have had liver function problem. But keep in mind, it's much less likely to cause a liver problem than, let's say, a statin. Okay, does having MTHFR gene have a negative effect on pregnant women? I'm so glad you mentioned that. Yes, we have found that women that tend to have people that have 1 or 2 variants in the MTHFR gene often they have more miscarriages than not. I don't understand the correlation or why that happens, but there is definitely a bigger propensity for miscarriages in those that have one of the variants. I've never read an explanation, but it's interesting. Also, there's other things about MTHFR. As a cardiologist, what I'm interested in is, does it have any effect on your homocysteine level? Because that's a risk factor that I want to treat, and it's so easy to treat with B vitamins, with appropriate B vitamins. But there are other things about MTHFR you might want to read about if you have a variant. There can be some interaction problems with other medications, but unless you're taking other medicines, you're okay. Good question. Okay. Thank you. Someone said, thank goodness, Dr. Elkin. Thank you, guys. Okay. I hate that insurance practice. I know. Insurance, I am the first person to tell you that they are not looking out for your health or my health. It's gotten worse lately. I have to get on the phone and talk with basically idiots that are reading off of a script card like this. Well, you don't meet the normal criteria. I had a guy that I was trying to get a nuclear stress test on. They wanted to refuse it. The guy's had a massive heart attack. He's got major heart muscle damage. And I can't tell you what strings I had to push to get this thing done. It's crazy. Okay. Does your book cover how to read some blood labs? Yes, it does. Some of these labs have changed since I wrote the book. But yes, I have 2 chapters on risk factors. One is called, I forgot what it is. One's the primary, the 6 major risk factors, and they're all heavily referenced. And the second chapter is, I call them the secondary players, the ones that aren't elevated to that of a main risk factor. But keep in mind, the one that puts this together is the Heart Association, the American Heart Association, which is very conservative, tends to be very conservative. I mean, to give you an example, they still tell you that canola oil is heart healthy. Are you kidding me? I don't know anybody that should be eating canola oil at this stage. Just watch the 2-minute video on YouTube and you'll see what I mean. So they still support that, and they still think that less than 8 grams a day of saturated fat should be your goal. Sorry, that's really last century. They are not up to date at all. So I respect what the Heart Association has done, but I do not call them up to date by any stretch. Okay, my symptoms are chest pain upon exertion. Oh, well, okay. So if you have chest pain on exertion, shortness of breath, you need to get tested. I mean, I have a very low threshold for doing stress testing. And again, if you are a female, and this is a female, you want to make sure it's done with either an echocardiogram, a stress echo, or you don't need a nuclear. A nuclear I kind of reserve for higher risk patients because I don't want to expose you to radiation unless you need it. But I mean, I'm seeing this trend now, which insurance doesn't want to pay for it. And so I get the patient involved. That you call them, you demand, that you have an imaging technique, because it's really bad. Okay. Yeah, didn't know about the jaw. Thank you, Liz. Yeah, I've never seen that in men, but I've seen it with women. Jaw, well, it's okay. Neck, jaw, and teeth. I can't give you a medical explanation for it, but that is a red flag for a woman if you see that. But again, women can have just dizziness, nausea. You have to have a high index of suspicion. And I should mention too, diabetics, which are, high risk, 70% of them will have a heart attack or stroke in their lifetime. They're the ones that often have silent heart attacks. I can't tell you how many echocardiograms, resting echocardiograms I've done on patients that are diabetics, and I see heart muscle damage, and they never knew they had a heart attack. So we don't want to, we're trying to avoid that, which is why, again, I want to do this kind of testing to avoid people having silent heart attacks. It's scary. Okay, so gestational diabetes. I don't think, listen, if you had gestational diabetes or preeclampsia, I know some of you have, I don't want you walking around like, oh my God. I'm doomed. You're not doomed, because they're looking at women that didn't change their lifestyle. Okay, the average woman and man are they're not looking at healthy people. They're not. It's just no one really talks about lifestyle the way I do. So when you're looking about statistics, they're telling you about people that were not healthy to begin with. So yeah, you go back to eating garbage, and maybe you end up with past gestational diabetes or preeclampsia and have a heart problem 20, 30, 40 years later. Remember, heart disease is still the number one killer in women. And we're going to talk more about this in May with Women's Health Month. But I'm a big advocate for bioidentical hormone replacement, because estrogen is so heart healthy. And women are basically devoid of heart disease, mostly until they go through menopause. And they lose the protective effect of estrogen. So, but it doesn't mean you're doomed. Okay. Well, thank you, Amy, for recommending my book. Okay. Yeah, I had a normal EKG with a tight blockage. See, that's why you have to look at everything as individual. I never had chest pain. Never. This arm felt like it was on fire. It wasn't, it was, it was just crazy. Okay, let me see. Let me make sure I get everything here. What supplements help with endothelium? Okay. So she was at microvascular heart disease years ago. Okay, so and you also mentioned Lyme disease. Lyme disease, we're still learning about it. It's so complex. But there are definitely, there's one supplement that I use. I use three different supplements, actually. One is, it has proteolytic enzyme. So I talk about the Greek stuff. So proteolytic means breaking down protein. So everything we do in life, whether we're shaving, eating, exercising, sleeping, every activity you do generates free radicals and also generates unwanted proteins. Now, normally when you're young, your body can fight all that stuff off. But as we get older, the body gets overwhelmed with these unwanted proteins, so it can't fight it off. Those unwanted proteins attack your endothelium. We don't want the endothelium. We want to remain intact as possible. Already we're dealing with pollutants in the air, the soil, the water, pesticides, dry cleaning stuff. There's so many things out there. There's so many toxicities that are destroying our endothelium. So we have to do everything in our power to maintain its integrity. So one of my supplements called Vascuwise, and that's proteolytic enzymes. You take two of them first thing in the morning, and it helps to actually gobble up unwanted proteins that can attack your endothelium. Another one I have has three major components called Endowise, and it has pomegranate extract. I'm sure you've heard of the benefits of pomegranate. So pomegranate extract, pine bark extract, and olive fruit extract. And together they help build the integrity in the endothelium. So one of these two gobbles up proteins that want to attack the endothelium. Other one helps to build, to keep the endothelium strong. There's a new one on the block that I'm using for more resistant cases called Glycocalyx Pro. So besides I told you before, the endothelium is one cell thick, and it lines all of our blood vessels. But there's one other thing I didn't mention. There's like a little gel that on top of the endothelium called glycocalyx, and that gel further protects the endothelium. So we have a product for that now too. People say, "Oh, well, you're just trying to sell supplements." No, I mean, I'm not trying to sell supplements. I'm trying to use supplements to their best advantage, and I'd rather take a supplement any day than a drug, especially if it's natural components. So. There are great ways of treating endothelial health and also staying healthy. Another good way to treat endothelial health if you're a menopausal female is hormonal therapy. And also for men, testosterone therapy, because these hormones help protect they produce nitric oxide, right? Nitric oxide is in the blood vessels themselves, and you want them to be dilated. You want to keep the arteries open. So again, hormonal therapy can affect your nitric oxide production. I'm very big on nitric oxide. Okay. Okay. Make sure I got everything, guys. I love all these questions. Okay, so I think we got it all. I just want to make sure. Give me 1 second, guys. I think I have it all. So let me tell you. So in 2 weeks, so the purpose of, let me see. Okay. In 2 weeks, we're going to do part 2, and we're going to talk really about lifestyle intervention. So the purpose of the day was to talk about testing and assessing your risk. What is your risk like, and how do you know how to assess your risk? And you don't know if you don't know what test to order. And if you go to a regular doctor, you're not getting a complete job. You have to demand it, okay? And if your doctor doesn't understand how to do it, I go elsewhere. It's just I don't get it. All they have to do is, if they send patients a request, they can call and get to be a provider on Cleveland Heart Lab. It has a different lab slip, and the patients just go to Quest. It's that easy. There's no reason why they can't do it. But I don't think the average doctor knows how to explain these tests. Not that I'm so super smart or special. It's just that this is what I do. I help people, interpret these results so that they know how to take care of themselves. And it takes time. The average doctor spends 5 minutes in the room with the patient. I don't do that. Any of you that follow by me, you know that that's the way I do things. So, but this is what I call satisfactory practice of medicine. So this is about how to assess your risk and what tests to order. But we're going to concentrate in 2 weeks on lifestyle. What can you do so that you don't have to worry about your endothelium so much, or how do we maintain health? And that's, regardless of what your genes are. Regardless, like I said, it's the trigger we care about, the epigenetics. So I want to talk about lifestyle, diet, exercise, stress management, sleep hygiene, things that most doctors do not talk about. But I think it's important because, again, this is Heart Month, and I want to just bring all that to light. So I want to thank you guys. Great audience. Thank you so much. And please share this with other people. And if you can, give me a thumbs up if you any of my videos, because ratings really, really do count. They really do count. So I greatly appreciate it if you can do that for me. And also my book. Now, I do want to tell you, I have a new website after about working a year. We finally have a new website with all of our supplements on there. Not only is it the picture of the supplements, but it's also the description that we painfully put together. So it's going to be really good. You never have to call my office and hear, oh, that's on back order. Oh, we're out of stock. Oh, we can't deliver it. This is all done by a third party, and that we have interviewed carefully. So you should have a much easier time getting supplements. And depending on my small office, I really can't handle the load. So you should be able to do that. And also my book is on that website as well. So please, if you haven't my book, it's available on Amazon. It's my story, but it's also how you can become your medical advocate. That's really my calling. My calling is to make you responsible for your own health, because the medical profession ain't going to do it for you. I can promise you that. The insurance company is not going to do it for you. Medicare is not going to do it for you. You have to be in charge of your own health. And you want to pick a doctor who aligns, that's the same kind of, we're in line with one another. I can't be the only guy in town, I mean, it's flattering, but it actually makes me upset to think that more people have not gotten on the bandwagon. That's where you guys come in, because if you demand it, it's going to have to be done. And you say, I want Cleveland Heart Lab. Well, I don't. Well, yeah. All you have to do, if you go to Quest, you can get Cleveland Heart Lab forms. So take charge, guys. And if you get my book, please, please, please go back to Amazon and write me a review, because, again, ratings are very important on books. I want to thank you, and happy Valentine's Day and happy Heart Month. As you can see, mine was great with my new granddaughter born yesterday. And I'll see you guys in 2 weeks, okay? Thank you so much. I appreciate you joining me. I'm very grateful. And we'll see you in 2 weeks. Okay, enjoy your weekend coming up. Thanks.